What's going on, everybody? Welcome to another episode of the Core Consults RX podcast. And this, unfortunately, is our second time ever having to re-record a podcast episode.
Womp womp.
Yep.
You know, we had the long lost acne episode.
From back in 2018.
Did you ever see that long lost SpongeBob episode?
I don't think so.
Before your time? Well, there was one. They did a whole thing about like the long lost episode. So that's what I always imagined our acne one as being. So we just had the one, but now there's two.
Now there's two. Yeah, so I thought I was, real fancy with these multiple camera angles and stuff going. Very proud of that. Unfortunately, I had taken them all. I had unhooked everything as we were getting something done with our floors and whatnot. But when I put them all back, I didn't test it properly. And so whenever the camera would switch to me, it would just be like this. Whoa. Like the entire podcast is like,
you could really,
these 5 or 10 minute like holes in it. There was some missing content for sure.
You could really only hear me and AJ talk, which is what's most important, I think.
That I will give you that. That is true. But, however, I add to the continuity of the episode.
It's mainly the long pauses that we would have.
It was very long pauses. We would have lost most of you. So here we are. We're talking about this again.
Yeah. So what's hilarious is we're probably still going to make as many mistakes as we did in the first episode. It hasn't gotten any, because it was a couple weeks ago that we tried to record this, so I've already had
to look everything back up again.
I had to redo whatever prep I did before the previous episode. I know.
So what are we talking about?
Yeah, so we're doing H. pylori again. Well, not again for y'all, but again for us.
Again for us.
Well, we have actually done it a long time ago in the past, but there is an updated medication, a new combo that came out with kind of a relatively new acid suppressing class, which I'll leave you there. We'll leave it on a cliffhanger till the end, and we'll talk more about that. Before that, we're going to get into a little more detail about H. pylori. We're going to update you guys on some diagnostic things, the treatment algorithms, which had kind of changed the last time we talked about it as well, and then we'll kind of hit that new drug too. So, what is H. pylori?
H. pylori, it's a spiral-shaped gram-negative bacterium. So basically what it does is it uses bacterial urease, and that hydrolyzes the gastric luminal urea and then converts it to ammonia. So this is basically going to provide like this alkalized protective cloud around the organism, and that's what actually enables it to survive in the gastric environment of the stomach. So catalase is another enzyme that is utilized by the bacteria that helps to block reactive oxidation from the phagocytes and cause inflammation that damages that gastric epithelial lining, and that's what can eventually lead to the formation of ulcers. H. pylori being one of the causes of peptic ulcer disease, and it's one of those that is very, very painful in some cases, depending on how bad it is and how extensive the infection is, and definitely something that we want to get treated and also heal up the ulcers as well. So when we get into the treatments, you'll see that the utilizing certain agents to actually heal that gastric epithelial lining is an important concept. As far as like the actual diagnostic, if a patient comes in, they're having severe heartburn, what have you, and we're trying to figure out if this could be, the actual an H. pylori infection or something else that's causing it. There's a few different diagnostic tools that we can use. So we can actually do an endoscopic rapid urease test is one option. It's a little bit more invasive. There's also the urea breath test, which is where the patient would ingest a radio-labeled urea. So they radio-label with carbon-13 or carbon-14 isotopes. And then this basically leads to radio-labeled bicarb byproduct that is excreted in the breath of the patient. And so you can kind of if you pick that up, that's indicative of a bacterial infection or H. pylori infection in the gut, because that's what's giving off that conversion. The caveats to this, it is a very good test. The caveat is you have to make sure that the patient has held their PPI dose for 1 to 2 weeks before the test, because otherwise you can get a false negative. Obviously, a positive test is definitive, but you can get a false negative, which can obviously delay therapy and whatnot. There's also the stool antigen test, which is just what it sounds, a stool sample. Not as fun for the patient, but this is actually the one that we use in our clinic.
I don't know. I'm imagining having to whatever the drink I have to drink taste like? I imagine it can't taste very good.
There's no drink. We put together like a kit for you to go home with, and it's like a little tube.
No, I'm
like,
talking
collection.
about the antigen test versus the urea breath test.
Gotcha.
Probably have to drink something kind of.
I thought
gross.
you were talking about like a bowel prep or something. For
No, fortunately, but no, yeah, even that. So the kit, I'd imagine, is easy enough, right? Is it a tube?
But you have to collect your fecal matter and then bring it back and present it back to the clinic. I feel like that would be awkward. People do it, obviously. We need it done, but I don't know. Be like, here you go. Drop this off for you. I don't know. I'm also a 13-year-old sense of humor, so that's fine.
I don't know. I've never used one of these before, so I guess I'm wondering, like, do they have a catch mechanism? You know what I'm saying?
No.
Surely they do.
Latex gloves.
Yeah. They give
Inside of the toilet?
you got to catch and throw, man.
I don't know what that means.
Well, I'll explain to you when you're older. With the stool antigen test, already off topic. This is why we have to redo episodes. With the stool antigen test, you do also have to hold the PPI for 1 to 2 weeks before the test, again, to avoid that chance of a false negative. There is historically serologic testing that you can get. However, this is not really recommended anymore because the problem with the blood test is it's hard to tell between an active and past infection. So if you get a negative result, obviously that can kind of help in that situation. But if it's positive, it doesn't mean that it's necessarily an acute infection that needs to be treated. It could have just been an infection that's already been treated, and we're still getting the serologic, positive testing.
Right.
So that's one is definitely not ideal to use, and we would try to stay away from that if at all possible. But yeah, stool antigen test, urea breath test, I feel, at least in my anecdotal experience, those would be the two that are most commonly used in like a outside clinic.
And I think the antigen test is a little more expensive. But yeah, those are both there. Interestingly, H. pylori, Helicobacter pylori, is kind of tough to treat, and they run into a lot of issues. So that's where the false positives after treatment would really throw a wrench in your plan, because it's pretty common to have, not pretty common, but reasonably common to have treatment failure and have to treat again or use some sort of salvage therapy. So if you're getting false positives and not sure if you need to retreat or not, that can be very difficult. The mainstay of treatment previous to an update into the guidelines a couple years ago was a clarithromycin-based triple therapy. That's not necessarily recommended first line all the time anymore. Only in certain cases it might be. Reason being, the resistance rates for clarithromycin have increased significantly. So effectively, they don't recommend that first line anywhere where clarithromycin resistance rates are greater than 15%. If you were listening to the writers of the up-to-date article on H. pylori treatment, they would say that they presume anywhere in the U.S. the resistance rates are greater than 15%. Therefore, they don't recommend this therapy as first-line therapy. So that's why the leaning has been more towards the bismuth quadruple therapy is what it's called. It's made up of 4 different medications, bismuth subcitrate that you would take 4 times a day, tetracycline 500 milligrams 4 times a day, metronidazole 4 times a day. Those 3 come in a pack called Pylera. It's the Pylera combo pack. You would add that to a PPI, a proton pump inhibitor, that you're taking twice a day for 10 days. You want to take the combo after meals and at bedtime, and it comes as dose packs with 3 tablets each that you would take 4 times a day, right?
Yep. And what's interesting is, so there's actually a pretty decent review article kind of going through all the different antibiotics that are utilized for treating H. pylori and how H. pylori has become resistant to those specific antibiotics. And so, like, for example, with clarithromycin, the way that the macrolide has its bacteriostatic activity is because it can bind to that 50S ribosomal subunit and it inhibits protein synthesis. Well, the H. pylori just has these point mutations that basically change, and now the antibiotic is no longer binding appropriately with that ribosomal subunit, and it's no longer able to do its thing. And there's more and more and more of those point mutations that are being discovered, and definitely something that we're not slowing down necessarily with the resistance rates, especially with clarithromycin, but others as well. But
Right.
they go through metronidazole, they go through levofloxacin. So I'll see. I think this is a free article too, so I'll grab this and post it in the show notes if you guys are want to nerd out on some medicinal chemistry.
Interestingly, with metronidazole, the resistance rates are very high,
Still use it.
But we still use it because strangely, it hasn't been associated with treatment failure like clarithromycin has, and they have some reasons for that. But the resistance rates are actually high. They just still use it because it still seems to work with the combo.
Yeah.
Yeah.
Did you mention the Pylori and the PPI being added to it?
Yes.
I was looking at the resistance thing, so I stopped paying attention for a minute.
Yes,
I did. I get distracted. But I will say too, the cost of Pylori tends to be something that gets brought up. There are definitely programs though that you can get access to Pylori very cheap. Like for example, FQHCs that have 340B pricing. My clinic, for example, has Pylori. I believe it's like $10, $15 for the pack, and then we just add a PPI to it.
It's pretty good.
Pretty solid.
So historically, what you'd have
That's
to do
cash.
if
That's
you
not
don't
insurance.
have that, if I was in a retail pharmacy, got sent that and it was not covered, and it was however many $1,000 or so, there's the option to split it into the separate components, which can still be pricey since you're taking so many tablets and 4 different medications. But yes, ideal if you can get some sort of discount pricing or other program to assist with covering it. If the insurance doesn't, but I guess the issue you might run into with insurance is that they're like just give them the 4 different drugs versus the pack. But some insurances will definitely pay for the whole pack.
And I believe you can. At least I think it's an up to date. The authors do say that it's okay to sub out doxy for tetracycline because that would be hard to find. Just plain tetracycline as well,
Yes.
I believe.
And also the bismuth subcitrate for salicylate, right? That's
I think the other way around, but yeah.
Yes.
But yeah, so that's the Pylori is, at least in my kind of thought, is that it's the one I tend to use first line, just because, like Cole said, the clarithromycin rates, unless you know for a definitive fact that it's less than 15%, it's not something to even mess with because you probably, or I shouldn't say probably, but you have a good chance of running into that.
Right.
Unless maybe you use this new med that we're going to talk about. Another cliffhanger. Look at that.
We're not there yet, though.
Okay, sorry, getting excited.
Getting too excited.
But I will say, though, speaking of clarithromycin, this is a good opportunity to kind of bring up our sponsor of the podcast, Pearls. If you haven't checked out the app yet, then definitely make sure you go to pearls.com/coreconsultrx, and that's Pearls, Pyrls. Their drug information app. And for example, if you look up clarithromycin, you can look up the tab that says Clinical Pearls, and it has antimicrobial spectrum of activity. So it talks about the H-flu and MCAT and some of the other gram-negative bacteria, the atypicals that it covers, whatnot. It also mentions the pore activity. It has monitoring parameters, and it's not as you have the more in-depth version of it as well, but this is like the quick bullet points that are like the important things to kind of pay attention to. So I like the way that they kind of have it separated out, so you can get the full robust amount of information if you really want to dive deeper. But this has just some of the highlights, the clinical pearls, if you will. So it talks about the renal and liver disease and potential needing dose adjustments there, QT prolongation if the patient is also on other medications that could prolong the QT interval, or if they've had a history of arrhythmias or low magnesium or something like that. But definitely a good little resource. So there's a free version that you can still get access to some really good stuff. So make sure you check that out. They've been really awesome about supporting the podcast. So check the app out, and if you like it, definitely upgrade to that pro version.
Upgrade.
All right. Anyways, do you like that? That was my sales pitch.
That was great.
Oh, thanks, man.
I like
AJ?
Pearls of the Day.
I've heard better, but it was pretty good.
AJ, God, you know what?
Just mute his mic.
AJ, mute your own mic. He's got to control the mic. He's gonna
mute both of us.
He's gonna mute me, and I'm gonna have to do this a third time.
So we mentioned the clarithromycin option, the option that has metronidazole and tetracycline. There's also more of a salvage option that's driven by rifabutin. It's a rifabutin plus amoxicillin plus omeprazole. It actually comes branded as Talicia, but that's a triple therapy. Rifabutin is, of course, a rifamycin anti-tubercular agent. It inhibits DNA-dependent RNA polymerase. Acts at the beta subunit and prevents chain initiation. Are some issues to be aware of with it if you need to use it. Skin rash, urine discoloration from the rifabutin. We're familiar with that. I can't recall what color. Red?
I think red.
Yeah, I think red. It's always red or orange.
Except for which one's blue?
The Urabel?
Yeah.
Or whatever it is, Euro
It's got,
MP.
like, the methylene blue in or something.
Yeah. Orange,
Anyway.
red, and blue. Mm-hmm. Can anything turn it green?
Probably. Oh yeah, isn't propofol turn your urine green?
Does it?
I think so. AJ, Google that for me.
I want it.
I haven't done inpatient in a long time.
What about black? Can't. Okay, we're gonna go through all the rainbow.
Oh my gosh.
Can't.
Sorry, everyone.
Can't.
Rhabdomyolysis.
Rhabdo can
Yeah, yeah.
be dark, right?
Yeah.
Maybe not black.
I don't know if it's a medication necessarily as it is a.
It's red.
Well-
It's reddish orange.
What is reddish orange?
Rhabdo.
Oh,
Reddish orange.
I had rhabdo.
Well, that just
it's
combines red and
Coca-Cola.
orange.
Of course you had rhabdo. Did you go for a walk and you got a little sore?
Got up out of bed.
I figured.
I had a technician who had rhabdo after like a really hard workout. She it was the next couple of days, she was just having a lot of muscle pains or whatever. They went in and she had rhabdo.
I remember this guy at a CrossFit gym one time. He was talking, somebody mentioned her. He goes, rhabdo's a myth, dude. And he was dead serious.
Just not real.
I said,
Psychosomatic.
I don't think it is. But okay, yeah, probably.
I don't think you can fake the protein spilling thing, right?
It's hard.
It's pretty difficult.
It is pretty hard. There's a lot of willpower there. Anyways,
Yeah, urine discoloration. Also, and we're talking about Talicia, the rifabutin combo, if you recall. Neutropenia it can cause, leukopenia, GI upset, so just some things to be aware of. The good thing about it is that H. pylori is highly sensitive to rifabutin with minimal resistance, which is why it's primarily safe for salvage, is to keep it that way and not cause resistance to rifabutin.
yes, absolutely. That's the last thing we need. We also have some other potential options. So I won't go through all these, but for example, we have like levofloxacin triple therapy, which is a 10 to 14 day regimen. And this is one they don't have like a prepackaged option, but you can kind of just put things, the meds together. So that would be a PPI twice daily, levofloxacin 500 milligrams daily, and then amoxicillin 1 gram twice daily for 10 to 14 days. That would be levofloxacin-based triple therapy. There's also a levofloxacin sequential therapy, which is where you do the PPI for the full 10 days, amoxicillin 1 gram twice daily for the full 10 days. And then all of a sudden on days 6 through 10, you just come in out of nowhere with levofloxacin. And also its counterpart metronidazole. And you just surprise them those last 5
Where
days.
they're least expecting it.
Just when they least expect, they Trojan horse those right in, and you take care of the H. pylori. So they call that levofloxacin sequential, and that's another potential option. There's several others.
There's several.
Yeah.
There's like
Hybrid.
there's hybrid, which is like a PPI days 1 through 14, amoxicillin days 1 through 14, and then you Trojan horse in the metronidazole again. It's a good Trojan horse on days 7 to 14. You also hit them with clarithromycin days 7 to 14.
I like that. You're like, let's take the two most resistant things and
just hit it at the
hit
end.
them at the end after you've weakened your opponent. It's a good strategy.
I don't really get that, but there's various ones. There's also a sequential therapy that is similar, but it's more like do the amoxicillin for a few days and then switch to the metronidazole, clarithromycin. They've got a number of options, but it seems like the bismuth quadruple is the easiest. And then you would go with some of these in a salvage situation.
Yeah, I tend to think quad first, and then from there, just patient specific. If we can use Levo, maybe. But if they're uncontrolled diabetes, and I want to stay away from fluoroquinolones, maybe I'll try like one of the sequential, or Talicia is in my back pocket, and then now, of course, we have our newer agents. And the reason why this has been kind of explored, and I shouldn't even say newer, because the one drug's been available in Asia, I believe, for a while. But the reason this has been explored is because, like we said, the PPI is kind of like just as important as the actual antibiotic that's eradicating the bacteria, because the PPI rather is what's there to help heal that endothelial lining of the gastric mucosa and fix that ulcer. And we know that PPIs have historically been kind of like the first line therapy for any type of NSAID-induced ulcer or any kind of gastric ulcer. And they work really well for that. The problem is to really like optimize the efficacy of a PPI, you have to ideally take it 30 minutes to an hour before a meal. So you take it on an empty stomach, because if it's brought into an acidic environment, then it gets disrupted and broken down before it can ever even get absorbed. And then so you take it on an empty stomach, it gets the small intestine, gets absorbed, and then those actual ATP ACE pumps those proton pumps have to be turned on, which happens whenever a person eats a meal and they need to start pumping out that acid. So they need to be in their quote unquote on configuration in order to truly bind properly. And so with the exception of Dexalon, that's the one, Dexlansoprazole is the one exception to that rule that can bind to off and on receptors pretty easily. But we have to kind of encourage patients to take something twice a day that has to be timed with meals to really optimize it. It's not like they won't work at all, but to optimize those, that can be somewhat difficult. And if the gastric mucosal lining is not being healed properly, then we may run the risk of also not getting clearance of the infection itself from the antibiotics.
Right.
So.
And then the peptic ulcer disease is going to continue.
Still there.
Yes. So that brings us to the new drug, right?
Yeah. So what are we going to do about it?
What are we going to do about that?
It's a good question.
So there's a new drug combined with a couple other medications in a new combo. There's two branded as the Voquezna triple pack and the Voquezna dual pack. The Voquezna triple pack is a new drug called Vonoprazan plus amoxicillin plus clarithromycin. In the dual pack, it's just Vonoprazan plus amoxicillin.
Oh, and ask yourself real quick, did they spell pack really, really cool? Where they left the C out and was like P-A-K.
P-A-K.
Of course they did.
That
wasn't that like the Nintendo 64's thing? It's like the Rumble pack. Like just
oh, yeah.
Yeah, they always were spelling it like that.
Yeah, like the Power Pack, P-A-K.
Because I remember my uncle, when I was like, I was probably 4th grade. My uncle was like, yeah, that's spelled wrong. That's dumb. I was like, oh, okay. Just try to play Nintendo.
You know who in the H. pylori space goes against that?
Ooh, tell me.
Prev Pack.
Prev Pack.
With a C.
Hey, well, guess what? They're the ones that everyone's resistant to, so.
I know.
Sorry about it.
Yeah, since I'm mentioning it, that's the one that you're probably historically have seen. Prev Pack is branded as, it's branded as Prev Pack, and it's lansoprazole, amoxicillin, clarithromycin, the clarithromycin triple therapy.
You spell it right, you get resisted.
That's what happens.
That's what happens.
So this is the Voquezna dual and triple pack PAK trademark TM. It says. So as you might have picked up, the Vonoprazan is the acid suppressing medicine, and it's not a PPI. It's not an H2 blocker. It's a first-in-class medicine from the FDA. Like Mike said, it's been around in Asia for a little while, and the class has been around since the 80s. But there was just too many side effects and adverse events from the kind of original medications that were studied that they were never approved by any significant accrediting body. So what it is a potassium-competitive acid blocker. So that's the first-in-class new class. It's going to end up doing a similar thing to the PPI. It's going to inhibit the hydrogen potassium ATPase to block acid from being produced. But it's going to generally act faster, and that's the kind of one of the significant things. I believe it can be without regard to meals.
Correct.
Yeah,
yes.
Which is a big difference.
You don't have to worry about when the person's eating.
They did compare it to, so Voquezna specifically, they compared it to, I believe, the lansoprazole. Yeah, the lansoprazole-driven triple therapy, and had it was superior to that in a phase 3 trial as far as eradication rates. Though I don't believe it's been compared to a quadruple therapy that I'm aware of.
And so, for instance, in that particular instance, the study itself was called Falcon HP, and it's spelled PHALCON-HP. Falcon. They're all about spelling stuff cool.
Falcon.
Yeah.
I don't know if I'd want to go to that conference.
We're going.
I'm just going to leave it there.
No. We're going. So in that particular study, you can check that out online. It's published and available. But the H. pylori eradication rate was 84.7% in the triple pack, the new medication combo, versus 78.5% with the lansoprazole, 78.8% in the lansoprazole-based triple combo. Yeah. So not a huge difference, but it was statistically significant, and definitely, and that was across the board as far as any type of clarithromycin, whether it be resistant or susceptible.
Right.
So you got better eradication.
So which was good.
Almost resistant rates.
Almost a bummer that they combined it with clarithromycin, because it's like,
what are you doing?
If we're going to do a new drug combo, why do this that's like not been recommended in a couple of years? But they did. But yeah,
because they're showing off.
It might improve if you want to use the clarithromycin triple therapy. It might improve rates. Interesting to mention that a lot of the studies for Vonoprazan itself were conducted in Asia, and patients of Asian descent tend to have higher rates of CYP2C19 extensive metabolizing. Mm-hmm. And so there is some thought that it's possible that the elimination of the Vonoprazan is independent of the 2C19, whereas PPIs are not, and this might have explained a stronger effect from synaprazan versus PPIs.
Sneaky.
Isn't that interesting?
That is interesting.
Yeah.
That makes complete sense, though.
Yeah.
I feel like that's a lot of things.
Yeah.
I haven't seen a price. Have you?
No.
I was looking to see if there's any updates. I haven't seen a.
When we recorded
AWP.
first, there was not a price.
I'm looking. Yeah, I'm just look now as we're recording this minute.
Oh,
and I'm
ooh.
still not seeing a price.
No prices.
Yeah. So that's what I'm concerned about too. Is I'm wondering.
Yeah.
How much more of the.
And if it's not in the guidelines, doubt insurances are going to pick it up.
Yeah.
So-
But at least we are, getting new options.
it's just
for
an addition-
something
yeah.
that we haven't had anything really that cool in a
It's
while.
just an additional option to try to throw it at it if you want to keep them on clarithromycin, I'd say.
And where I'm excited to see where this goes is to see how this gets implemented into like managing, ulcer, like GI ulcers in general,
Right.
Whether it be NSAID induced or what have you, because I think this could be, really besides PPIs, we don't really have a great option. We have sucralfate, which is garbage, and we have like misoprostol.
Yeah, that's true. I didn't really think about it for other indications.
Yeah, so that's where I'm excited. So hopefully this will be another, finally another class of meds that we can use for ulcer treatment.
I mean, it sounds like it acts as fast as an H2.
Maybe faster.
But then lasts longer. It might
Like
be
a
more
PPI.
like PPI. And so, I guess I'm interested to see if it has the same long-term concerns as a PPI, like we won't go into them all, but all the plethora of long-term adverse effects that people are concerned about with long-term PPI use. I'm interested to see if...
My guess is it would, because those are all
Is it
centered
all related to
around
acid suppression? Yeah.
So my guess is it would,
But they're not with H2s. Is it just because they don't last as long?
they just don't suppress as well.
Don't suppress as well? Yeah, because these are going to end up acting on the same mechanism. Mm-hmm. Yeah.
So
Interesting.
We'll see.
Yeah. Important to note that you do want to confirm afterwards that the H. pylori has been eradicated. So similar tests that you're going to use to diagnose, you can use to confirm the eradication. Urea breath test, fecal antigen test. An upper endoscopy can be performed 4 weeks or more after completion of the antibiotic therapy. Definitely wouldn't be standard of care there, but maybe if you were concerned about certain things. So I've known individuals who were having, dyspepsia and other concerns, and maybe they had a history of stomach cancer in their family or something like that, and so they did an endoscopy to check things out, make sure that they didn't have esophageal, what's
Cancer.
the word? Not cancer, but like the just
Like polyps?
erosion.
Like Barrett's esophagus.
Like Barrett's esophagus type thing, yeah, or even in the duodenum, just to check it out, and then maybe they find H. pylori at that same time, treat it, and so maybe they'd want to do a repeat in that instance, but that's not my area of expertise, so I won't.
Well, and the other thing
Postulate.
I'm wondering too, like, is if you have a patient on a PPI to heal that gastric ulcer, you still would have to wean them off the PPI as opposed to just abruptly stopping it, because you're still going to have that acid suppression, which could give really bad rebound.
Yeah, so it's only the 2 weeks, and you still would need to, right?
Yeah, it would be obviously a lot easier than being on it long term, but I would imagine that you'd still if you stop it abruptly, there still could be a little bit of residual rebound dyspepsia.
People don't use, it's not usually a standard screen. H. pylori is not really a standard screen. Usually there are some symptoms or some family history or some other comorbidity that's going to prompt you to test for it.
From a certain geographical location.
Geographical location. So dyspepsia is probably a really common reason to come in for it. So if you discontinue the PPI immediately and then dyspepsia immediately comes back, then they're going to come in and then they're going to have to test for treatment failure and all this kind of stuff. It's good.
Yeah, that's the problem we run into all the time is when we're testing people for this, is they've been on PPIs over the counter for who knows how long.
Yep.
And so it's like we have to try to wean them off.
Yeah, or even prescribed in many instances.
Yeah.
Maybe even twice a day. They prescribe it before they... Yeah, it seems like they should be a little... To me, especially with how prevalent... We mentioned in the first episode, but I can't recall the stats. I gave some good stats in the lost episode.
They're lost.
But the prevalence of H. pylori is extremely high, and it's spread frequently to your family members. It's spread... Like your spouse is more than likely, if you are colonized, they're probably going to be colonized as well. So it's all over the place. It's just that we only treat certain patients. There's no recommendation to test and treat everybody. If you find it, the general recommendation is to go ahead and treat it, but it's just not a recommendation to find it in everybody. It's all over the place.
26 billion people a year infected.
It sounds like more than the amount of people alive, but
Well, maybe that's not a super accurate stat.
you're counting like dead people too.
I like that both of you were kind of like, is that wait? That seems like more.
That's about like when I said the
Spanish flu.
Spanish flu killed like 100 million people, and
Yeah,
it
you
was
said I
not-
can't remember what you said, but it was a lot. It was more than they killed.
Maybe it was 100 million. No, I'm not
can't-
going to say that again.
Yeah.
Where I'm
Well,
just going to go with I can't
do it.
remember.
Yeah.
At least 5.
At least.
Oh,
yeah.
definitely 5.
Less than, or I should say greater than or equal to 5.
Yeah. If only there was a website that would tell us all the stuff we want to know. If we just ask it, that would
Yeah.
be cool. Someone should invent that.
Anytime that me and my wife are having one of these conversations, she just hollers at Alexa to ask for the answer. And I'm like, I just like talking about it. and
Alexa's getting good.
I know.
You're such a boomer. I just want to talk about it. I don't want to actually look it up.
I know. I'm a boomer.
All right, man. Anything else with that?
That's all I got. We
All right.
got them updated
Short-
on the
short
new
and sweet.
thing. Yeah, I like it.
AJ, we miss anything?
Propofol confirmed. Blue-green urea.
There it is.
Blue, green. Do we have anything for yellow?
Water.
Well, that would be
Well,
clear, maybe, hopefully.
Depends on how much
Yeah.
water you're drinking.
Not
if you're
enough
dehydrated.
water.
Well, I will say, I know we've talked.
Phenazopyridine is like an orangish yellow.
Yes, I know we've talked about the asparagus before. We won't get into that now,
Yeah.
but
That smells good.
does it? I've never asked you though, AJ. Does it make your pee stink?
It does.
Okay.
Well, stink. There's an aroma.
It
I
turns
wouldn't say
out
it's
that
an
it
odor.
makes everybody's pee stink. Only certain people can smell it. That's
What?
the deal. We talked about this on the podcast.
I feel like we have, but that's so disgusting.
our listeners are thinking, Mike, how do you not remember this?
He just admitted that he can't smell it. That's what it is.
doesn't make
No,
you.
I definitely can't, unfortunately. But it's why I don't eat asparagus. It's disgusting.
I like asparagus.
Do you?
Yeah.
Nah, I can't deal with it. Some people estimate death ranges is possibly as high as 100 million.
Okay, so it was 100. So
Second deadliest pandemic. So
what could I have possibly said that was too high?
I think-
I didn't say 1,000 million.
Maybe you did.
I didn't.
That's a billion. Pretty sure.
Sure is.
Maybe, I don't know. Maybe you said 400 million. I don't
Oh,
know.
you know what it was though? The swine flu. I was talking about. I said the swine.
You were talking about swine instead of the
Yes,
Spanish
I was
flu.
talking about the swine flu. I said 100 million, and
That
I
was the
meant to
confusion.
say Spanish flu.
That's okay. That makes sense.
Yes.
Well, live and learn. That was episode 3, so we've improved. Well, that's debatable, but we've tried really hard to improve.
I was
bit.
looking back on the YouTube videos from back then, and we look like children.
Dude, I still look incredibly young. That's what's so crazy, right, AJ? People see me and AJ and they go, "You guys are the same age, huh?" And I go, "Yep."
Not once.
24.
They've never said that.
They say it to me all the time. They're just not around. In fact, they ask, "There's like, is that your older cousin or something?" And I go,
The
"Yeah."
progression of your beard is pretty interesting. I didn't
it?
have one at the time, but like yours was really long, like when we first started the
did,
podcast,
yeah.
and it just long, short, long, short.
Yeah,
kind of
it changes with the weather.
thing. Yeah, that makes sense.
Oh, now that we are so far off topic, it's not even funny. Anything else before we wrap it up?
That's all I got.
All right, you guys. Well, I'm sorry about the last 3 minutes of just utter nonsense, but it is what it is. You guys know what you get when you listen to us. So thank you guys so much for sticking with us and checking out the podcast. Still, we're slowly approaching episode 200, so we really, really appreciate the support from everybody. If you have any questions for any of us, reach us on our emails in the show notes below. You can reach us on any of the social media platforms. You can also send us a text directly, which the number will be in the show notes because I have to update the app and I don't have it in front of me right now, so that's great. Also, if you want more traditional lectures without as many where we go off on these rabbit trails and whatnot, and actually stay on task and sounds a little bit more traditional lecture style. Patreon, that might be more your jam. Patreon.com/coreconsultrx, and there's tons and tons and tons of PowerPoint slides, lectures, pharmacotherapy practice questions, all kinds of stuff. So check that out. That helps us keep the show rolling as far as the proceeds from that. And thank you again to Pearls as always. And we'll see you guys in the next episode. Bye.